two patient panelists, Mr. Seung-gi Ra, he's from Korea, and Melanie Vincelli from United States. First, I want to ask Mr. Ra, where's Mr. Ra? Yes. You may look at all the panelists. Among them, just guess who is the least likely who have received the gastrectomy. Choose one. Maybe on the far right, far left from your side, Mr. Ra. Could you share some your experience with our audience?
My name is Seung-gi Ra from South Korea. I took the PPG more than 20 years and 2 months ago. So I was survived from the early gastric cancer. But everybody said, what is your advantage and disadvantage? I think there's a bunch of advantages, but one disadvantage is I cannot lose my weight. This is a big problem all the time. Thanks.
How about Melanie?
I'm a stage 4 gastric cancer survivor. I was given 6 to 9 months to live 14 years ago. I had 6 rounds of chemo. I was no evidence of disease, and 14 years ago I was lucky enough to have an amazing surgeon that removed my stomach totally. I have a total gastrectomy. In 2015, I was diagnosed with the BRCA2 gene, and this is why I ended up with gastric cancer. I have to tell you, as I sit here before you today, after given 6 to 9 months to live 14 years ago, I've gotten to see 3 grandchildren I never thought I'd be able to see. I travel, obviously. I also travel with my husband. We take care of our grandchildren. The only problems I have are self-inflicted. It's when I eat too much, I eat too fast, and eat stuff that I shouldn't be eating, and I know it as I'm doing it. I have to tell you that I've been one of the very, very lucky ones that have survived this long and come this far in my journey, and I really don't have that many issues. The proactive bilateral double mastectomy gave me more problems than losing my entire stomach ever did. So I have been extremely, extremely lucky. And I can't gain weight. So if you want to give me some of your weight, that'd be fine. Yeah. We got to figure that out. Yeah, we got to figure that out.
And our other panelists are Dr. Kao from Shanghai and Dr. Berlitz from Mainz, Germany. Maybe the two of you could give us some comments on how you select patients for PPG versus a total, because I think that's the issue here to discuss.
Thank you. Because my hospital is a high-volume gastric cancer hospital, and is also one of the largest gastric cancer center in Shanghai. So I think for the PPG is including the FPG, included the several method of the, for instance, is the PPG is one of the FPG and the PG and the local resection, and even the ESD also belong to the FPG. That is means FPG is the less stomach resection and prevention of the nerve and the vessel and the normal anatomy of the stomach. So this is, we should select some early gastric cancer, because this part of the patient is also limited. We should make the very previously for the before the operation, we should precision diagnosis. And 10 years ago, when I visited the Seoul National University Hospital, followed by the Professor Yang, I saw this PPG is routine surgical procedure in his hospital. Then I think it over why he and his team use this method for the early gastric cancer, because the very high incidence of the early gastric cancer in Korea and in Japan. So I remember when 25 years ago, I have the clinical training in the Tohoku Rosai building. The Professor Maki, he is the pioneer of the PPG in 1967. But at that time, PPG is used for the benign ulceration for the gastric patient. So now, when I come back to China, I send my team to Seoul National University Hospital and learn this technical. And we go back, we practice, and select some small amount of the patient to perform this PPG, the surgical procedure. You know the PPG technical is different compared with the distal gastrectomy. It quite demanded high technology. So gradually, we get the technical, and now is the number of the PPG patient in my hospital is over the 300 patient, and we make some Chinese consensus for PPG, and we make the surgical step in details and tell all the few interesting Chinese surgeons to learn these technicals. And we make some seminar, conference, and more now. More and more the Chinese surgeon to perform this PPG surgical procedure. And in some conference, in some congress, the PPG always one of the topic in the meeting. Yeah.
Thank you very much,
Okay.
Professor Kao. And Dr. Felix Bert, not only for PPG, how about the preserving any stomach in European country? Can you make a briefly comment on that?
Yes. Hello, everybody. My name is Felix Bert. I'm a surgeon from Mainz University in Germany. And I had the great opportunity to study 2.5 years with Professor Yang in Korea, which, of course, draw my attention towards function-preserving surgery. Still, I think in this session it is important to say, especially also me coming from a Western country where we deal with more advanced disease, that first the disease will determine the extent of the surgery usually. So we should not try to force a function-preserving surgery for the price of missing a chance of cure. This is a very important message, especially for us treating the more advanced stages. And then, on the other hand, I think if a case or a cancer or a patient applies for function-preserving surgery, for me personally now, it is not an excuse that I practice in Germany not to try to apply those techniques. So I did, also in a very limited number of cases, but I think it is possible, and I think it's good that we do. Of course, we have to go to Asia to learn those techniques, this is for sure. But number three, I think in the West we would have a little bit different understanding of the definition of function-preserving surgery, and this is what Professor Yang refers to. So I think we have more chances to preserve some part of the stomach. So we have more indication for partial gastrectomy as we think. Giving you the example of my institution, where when I came back from Korea, the rate of total gastrectomy within all gastrectomy cases dropped from 75% to 25% now. This is a substantial change in our practice, and this is not by bending the oncological principles or treating the patient less radical for the cancer.
So we spoke about the inaccuracy of EUS and CT scans. How do you get around that issue, especially in Western countries where we know most of the patients are very advanced?
We do frozen margin investigation not only in any case of stomach preservation. So if we do any case of partial gastrectomy, per principle, we apply frozen section, number one, for the luminal safety. Number two, we do also apply frozen section for lymph node stations selectively. So if we, for instance, in proximal gastrectomy, if we preserve, we preserve less stomach than probably in a proximal gastrectomy in Japan or Korea. But we do apply frozen section for even unsuspicious lymph nodes in the area that we preserve, just to make sure that we would do anything we could not to miss information.
Do you do random sampling or do you do sentinel node?
We do both. We use the ICG, but I think sentinel node is not something that I rely on. So we do extensive sampling, let's say, because I also learned the way how to do vessel-preserving lymphadenectomy. So it's more than just a picking that we do, and but we know from other data also which kind of cancer would apply for a proximal gastrectomy, for instance.
Okay. Professor
Okay.
Sisson.
To perform function-preserving gastrectomy, the diagnostic accuracy is very, very important. So for PPG or proximal gastrectomy, we should be very careful to select patient based on varieties of techniques like CT scan and endoscopic ultrasonography and so on. And also, as you mentioned, Dr. Velt, frozen section use is very important in some cases and critical borderline cases. And regarding the case of Katerina, even in Japan, there is some mythological belief that signature cell equal squamous type, so Bowman type 4 cancer. So even a small tumor in the body, many Japanese surgeons recommend them to undergo total gastrectomy. It's not completely necessary at all, to my opinion.
Yeah, that's what Dr. Felix mentioned when he returned back to Germany.
So I think that kind of knowledge is very important, and it's kind of myth, not scientific evidence. So signaturing cell and poorly cohesive cancer is not always as bad as some doctors supposed to be.
Yes, thank you very much, Dr. Sosako. And now we may have to wrap up, and I will summarize a little bit, and Dr. Coburn also give us some advice to audience or virtual audience too. This session, you noticed that doctors, surgeons are developing different procedures to preserve as much as possible stomach. But the important is the indication. If it is a Ollis lesion, we can go even endoscopic resection. But indication, very important. We don't want to leave behind any cancer metastasis. And but on the other hand, as you noticed, our patient panels not much matter how much stomach you have. Yeah, even though PPG our Mr. Ra complaining of I gain weight, too much weight, difficult to control my weight. So this is a message. Although it takes time to recover, so don't be much stressed, even though you have a total gastrectomy. And yes, Professor Mariama.
Yes. Thank you. I'd like to congratulate to Ekaterina and Natalina. This is the typical advantage of surgical treatment for gastric cancer. The first advantage is rescue or survival from the disease. That's a very important factor. So Dr. Katai emphasized that the indication of which surgical treatment is suitable for each individual patient we have to consider. And in case of total gastrectomy, looking very nice for you. I'd like to emphasize that after successful gastric cancer surgery, the second advantage is become beautiful, good posture. And because of the prevent the obesity, patient can survive more than normal patient. This is a statistical study of nationwide registration of gastric cancer in Japan. Probably 2 and a little more survivors comparing to normal patient. So please, congratulations.
Thank you very much.
And one point.
Oh, yes.
Vitamin B12, that is essential for the patient after total gastrectomy. But vitamin B12 is stored in the liver usually 4 years. Very storage, easy to storage. So every month injection you had, that's very painful. So you can reduce the number, for example, 6 months interval or 1 year interval. Please calculate the amount of vitamin B12 in the ampoule. Usually in Japan, we inject every 6 months 2 ampoules. That is enough. Thank you for your attention.
Thank you very much, Professor Mariama, your great from your great experience and knowledge. And again, for the audience, and the big message here is detection. So if you are in Japan, Korea, don't miss every other year health screening provided by government. If you didn't receive gastroscope within last 2 years, today you have to reserve it. And people who you have any symptom, don't ignore. The most common symptom is epigastric pain. So if it continue about like weeks, go to the doctor. And finally, I also would like to appreciate the doctors here. This is an education symposium. Doctors may not have to be here. They may be bored, but no, they are here and willing to give advices to our patients. So this international educational program, next year, Chinese doctors, they say, yeah, we should have in China. So please, Dr. Koban, a message to our patient.
Yeah, and thank you for the patient advocates for sharing your stories and assisting us all with the education for both the physicians, the caregivers, and the other patients. And we'll close this session and move to the next one. Thank you.